Thank you, Dr. Rofsky. It's my pleasure to be here today speaking to you today, and without further ado, on to preoperative screening exams. I've got nothing to disclose. Here's a brief outline of what I'll be discussing today. We'll go through the definition and rationale for preoperative screening tests. I'll talk about the two main tests that are out there, the chest x-ray and cardiac testing. I'll touch on some surgical risk classification systems, go through recommendations on when you can do and not do preoperative imaging, and give you some conclusions. So what are we talking about when we talk about preoperative screening exams? Are we talking about something like a knee MRI prior to ACL reconstruction? Well, that's not really what we're talking about. We're talking about things that are intended to be performed on a routine basis for all patients prior to general anesthesia. And again, these are the two types of studies that we're going to be talking about. The main purpose of them is to detect subclinical abnormalities that would change your management, whether that's changing the anesthesia technique, changing the timing of surgery, or the need for surgery. And the key thing is that these are subclinical that you might not know about. That's the other thing for cardiac imaging is to stratify cardiac risk. Well, what does that mean? That's basically assessing the risk that they'll have during the perioperative period, some untoward cardiac event. The two most common and worrisome things, which would be perioperative heart failure, or more importantly, a myocardial infarction. Why myocardial infarction is important is because in the perioperative period, the mortality rate is extremely high, estimated at between 30 and 50%. Do keep in mind, though, that's only if you do sustain the myocardial infarction. The risks of surgery are much lower. The surgical risk itself, even for high-risk procedures, is the mortality rates are 1 to 2%. So in today's climate of evidence-based medicine and population health, we're lucky that there's lots of new resources available to us. And if you haven't done so already, I highly recommend the Choosing Wisely website. Choosing Wisely is a partnership of the American Board of Internal Medicine Foundation with Consumer Reports. And the purpose is to avoid wasteful or unnecessary medical tests, treatments, and procedures. And on the website, you'll see a list of evidence-based recommendations by various subspecialties, training modules for clinicians, reference articles, and other sources for implementing Choosing Wisely in your practice. And just a little bit of background on a chest x-ray. It's one of the most commonly performed procedures in the U.S., with estimates ranging from 112 to 150 million exams a year. So if you take the CMS payments for chest x-rays, about $37 for a two-view and $23 for a single view. So if you average $30, we're spending about $4.5 billion on chest x-rays. And it's actually estimated that 60% of inpatient and 30% of outpatient exams are being done for routine or screening indications. So as you can see, that's a large amount of money we're spending, and it's a high cost to society. So moving on to the chest x-ray, I don't have any exciting images like Dr. Fetzer. I think we all know what a two-view chest x-ray looks like. It's a frontal and lateral view. And I've already gone through some of the reasons why you would do it. Things that you might find if someone has bad lung disease, that might change the anesthesiologist's proposed way of doing the anesthesia. If you found a pneumonia and they're supposed to undergo a joint replacement, you'd obviously want to postpone that. Some things you might find may preclude the need for surgery altogether. If they were undergoing a liver transplant and you found, lung cancer, you wouldn't want to go forward with a liver transplant. And it's also a baseline for postoperative studies. That's mostly for cardiac imaging, cardiac transplant, and cardiac bypass surgery. So we're about to get to some of these recommendations, and when I give you the recommendations, it's going to say a whole bunch of things. Do keep in mind whether it says the patients are symptomatic or asymptomatic, whether they have risk factors, and also the type of surgical procedure. Is it cardiac surgery or non-cardiac surgery? And is it a low, intermediate, or high-risk surgical procedure? So finally, here are some recommendations. These are all from the Choosing Wisely website. Both the American College of Surgeons and the American College of Radiology recommend to avoid admission or preoperative chest x-rays for ambulatory patients with unremarkable history and physical exam. And the American College of Physicians recommends against obtaining preoperative chest x-rays unless you suspect intrathoracic pathology. So the ACR appropriateness criteria, I'm sure you're all well versed in it and others have already touched on it, so I won't spend a lot of time on that. But just we'll go through, the ACR is one of the societies that contributes to choosing wisely, so let's make sure they put their money where their mouth is. And so for the clinical condition of routine admission and preoperative chest x-ray, variant 1 up here in the top left, asymptomatic, history and physical, unremarkable, the preoperative chest x-ray gets a rating of a 2, so it's not indicated. You don't have to do it. The evidence stands behind you. However, variant 2, with acute cardiopulmonary findings by history or physical, the appropriateness, I don't know why they changed it to the preoperative chest x-ray to the bottom, but it goes up to a 9, so you definitely would want to do it. It's highly indicated. Kind of going out of order, variant 4 over here says chronic cardiopulmonary disease in the elderly, which is defined as above 70. If they haven't had a previous chest x-ray within 6 months, a preoperative chest x-ray gets an 8, so you would want to do it. If they do have a chest x-ray within 6 months, it drops the rating to a 6. So you just have to stratify based on how much chronic disease they have. So where are these recommendations coming from? I'm going to try to go through a few of the cited literature articles that give you an idea of why they've come to these conclusions. This first is a paper out of McGill University in the Canadian Journal of Anesthesia in 1993. It's a meta-analysis involving all studies describing preoperative chest x-rays done from 1966 to 1992. There were over 14,000 exams in the meta group. They did find abnormalities in about 10% of the cases. However, only 1.3% of those abnormalities were unexpected, and even less, so 0.1% resulted in a change of management. That's 1 in 1,000. So with 1993, the cost of a chest x-ray was $23. That means you'd have to do 1,000 x-rays and spend $23,000 to find one actionable item. So some more recent data coming out of the Emory Clinic in the radiology literature in 2001. This looked at their outpatient screening population. They did about 3,800 outpatient chest x-rays, and about, like other estimates said, about 34% of those were done for the routine or screening indication. And for the purposes of this study, they categorized the x-ray as normal, minor finding, or major finding. And just so you know, what they said it was a minor finding is something like age-related changes, old granulomatous disease, a healed rib fracture, whereas things like major findings included like a pneumonia, lung nodules, lymphadenopathy, or masses. And their findings were very interesting. No major abnormalities were found in patients less than 40, and only 15, and this is not percent, that's patients out of those 1,282, so it's around 1%, had a major abnormality. Even more interesting is that further evaluation of these called abnormalities on the chest x-ray, 14 out of those 15 turned out to be false positives when they had additional, more advanced imaging. Only 1 of the 15 was found to have a true finding. They were diagnosed with stage 1 sarcoidosis for mediastinal lymphadenopathy, but because they were asymptomatic, they required no treatment. So to find that one major abnormality, they had to do 1,282 x-rays, and the cost for the x-rays and the imaging was over $46,000. So again, a lot of money invested, a lot of people getting x-rays with very, very little yield. So the bottom line for preoperative screening chest x-rays, it is not needed if you're healthy with a normal physical exam. However, it is recommended if you have active symptoms or abnormalities on physical exam, or if you're above 70 with no chest x-ray within 6 months. So moving on to the cardiac imaging. This is again done for cardiac risk stratification, the risk of developing heart failure or a myocardial infarction in the perioperative period. Do keep in mind that high mortality rate, which I already went over before. And the types of imaging we're talking about here, it's the transthoracic and transesophageal echo, usually performed with stress. You can do radionuclide cardiac stress testing. This is also known as SPECT myocardial perfusion. This can be done with either physiologic stress, which is like walking on a treadmill, or pharmacological stress. And there's also stress MRI, and recently stress CT has also entered into the fray. One thing, if you guys are not aware of, that you all should be, is the Center for Medicare and Medicaid Services Outpatient Measure 13. This is one of the measures that CMS tracks for the hospital outpatient quality reporting program. And if All the hospitals where you guys practice, if they do any form of cardiac stress testing, they will have a report for this that patients can see on the website. And what it looks at, it's the percentage of cardiac imaging that is being done prior to low-risk surgery. And CMS thinks that this percentage should be 0, so that you shouldn't be doing cardiac clearance exams in patients undergoing low-risk surgery. So what, you may ask, is a low-risk surgery? Conveniently for that CMS outpatient measure 13, CMS defines it for us down to the CPT code. This is a list of the procedures, and in a nutshell, it's breast procedures, and then anything you can do with an endoscope, either in the ENT world, bronchoscopy, upper and lower GI endoscopy, urologist doing kidney, ureter, or bladder endoscopy. Lithotripsy falls in this as well. OBGYNs who do hysteroscopy also fits in this. Cervical procedures, some minor laparoscopic surgeries like lysis of adhesions, and then cataracts and other superficial excisions. And I would encourage you to go to the CMS website if you have questions. It's very easy to find. I'll use this kind of as a segue to talk about more generalized surgical risk stratification. The American College of Cardiology and the American Heart Association also have a joint kind of differentiation. If you look at their low-risk categories, these are very similar to the CMS list. And here they also assign the relative risk of untoward cardiac effects. For the low-risk procedures, it's less than 1%. Compare that with these high-risk procedures where the risk is greater than 5%. These are the major and emergent major operations, cardiac, aortic, and other vascular surgery, or anything that's going to be anticipated to have a long surgical course, large fluid shifts, or blood loss. And then the majority of surgery falls into this intermediate risk category where the risk is between 1% and 5%. So now we're going to move on to the recommendations for cardiac stress testing. And again, keep these same things in mind when you read these guidelines because they are very specific. And again, all these guidelines come from the Choosing Wisely website. The American College of Cardiology recommends against performing cardiac stress testing in patients scheduled to undergo low-risk, non-cardiac surgery. The Society of Thoracic Surgeons recommends that patients who have no cardiac history and good functional status do not require stress testing prior to non-cardiac thoracic surgery. The American Society of Anesthesiologists is a little bit more cavalier. They say you don't need stress testing even if you have known cardiac disease, such as coronary artery disease, valvular disease, if you're having both low or moderate risk non-cardiac surgery, as long as you're asymptomatic and stable. This American Society of Nuclear Cardiologists says you don't need to perform nuclear medicine stress tests if you're undergoing low or intermediate risk non-cardiac surgery. There's lots of them. The Society for Vascular Medicine recommends avoiding cardiovascular testing for patients undergoing low-risk surgery, and hopefully you all see some trends here. And not to be outdone, the Society for Cardiovascular Magnetic Resonance says to not do stress MR if you're undergoing low-risk non-cardiac surgery. Phew. So let's try to make some sense out of all these. I think it's a little bit easier to do the don'ts first. No society advocates preoperative clearance for low-risk surgery, okay? Some societies take that a little bit further and include low and intermediate risk, like the nuclear cardiologists. And as we said before, the anesthesiologists were the most cavalier and said you don't need it for low or intermediate risk, even if you have known risk factors, as long as you're asymptomatic. So the do's. This is kind of obvious, but it's a good idea to get preoperative clearance for cardiac surgery and other major vascular things. And do keep in mind the game changers, active symptoms, which is the most important. If someone has symptoms of atypical chest pain or angina or CHF, you're going to want to do a preoperative evaluation for those patients. Unless, the risk factors, this gets a little bit dicier. They do have recommendations for all this laundry list of risk factors, but that's kind of beyond the scope of this 15-minute talk as I'm running out of time already. The Cleveland Clinic webpage titled Cardiac Risk Stratification for Non-Cardiac Surgery has a really nice outline and can help guide you if you have questions. So some conclusions. Preoperative evaluation is not necessary in asymptomatic patients without risk factors. Active symptoms require preoperative evaluation. And finally, asymptomatic patients with cardiac risk factors may need preoperative assessment for intermediate and high-risk procedures. Thank you.